Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome back again. This is the last session of the first day of vein thromboembolism prophylaxis day. It was very intense scientific program. We started by 200 audience or attendees. Now it's 50. Great, 50, but are paying attention better than 200. Okay. Without further ado, it's my great pleasure and honor to present Professor Roopen Arya. He's a professor. Roopen Arya is a director of King's Thrombosis Center and professor of thrombosis and hemostasis at King's College Hospital. He trained at Oxford and King's. His main interests are venous thromboembolism, thrombophilia, and the new anticoagulant. He's passionate about advancing safety and quality of care through innovative and patient-centric approaches to thrombosis care. He's a national clinical lead for VTE and director of the National VTE Exemplar Centers Network in England. He will talk today about implementing system-wide VTE prevention, a multidisciplinary approach. Please welcome with me Professor Roopen Arya. Okay.
Thank you. Salam alaikum. Apologies for the technical difficulties, and thank you for inviting me to speak. So I'm going to speak about a topic that is very dear to my heart, which is implementing system-wide VT prevention. We've heard earlier this afternoon from several of the speakers about the more specific approaches to thromboprophylaxis, but I shall take a little more practical approach in my talk. Those are my disclosures. Now, venous thromboembolism, we all know, is, along with myocardial infarction and stroke, part of the unholy trinity of cardiovascular disease, affecting 1 to 2 per 1,000 population, and can present either with acute venous thromboembolism, and nearly up to 50% of patients can have post-thrombotic syndrome, 4% can develop pulmonary hypertension, and an up to 10% annual rate of recurrent venous thromboembolism, and a very significant mortality. And really, it's a very significant burden, both in human and economic terms. So just some headlines to start off with. Venous thromboembolism is common in hospital patients. We know that nearly half of all cases of VTE are attributable to being in hospital, whether for surgery or with a medical illness. We know that VTE is bad with a very significant morbidity and mortality, and we know that we can prevent half to 2/3 of these cases by administering prophylaxis, and hence the prevention of VTE should be standard of care in hospitals. There are more than 400 randomized studies that prove the safety and efficacy of VTE prevention, and guidelines have recommended routine prophylaxis for over 25 years. Consequently, the Agency for Healthcare Research and Quality in the US, when they examined about 70 different patient safety interventions, named thromboprophylaxis as the #1 ranked patient safety strategy for hospitalized patients. And really, the available evidence stretches back for more than half a century. The first study in hip fracture patients was published in 1959, and subsequently work from King's by Professor Kaker demonstrated reduction in both DVT and fatal pulmonary embolism with the use of unfractionated heparin prophylaxis. So Professor Kaker was professor of vascular surgery at my hospital, and bless him, he passed away just about 3 weeks ago in London. So this was one of the first studies showing the efficacy of prophylaxis in preventing both DVT and fatal pulmonary embolism. And subsequently, there have been studies confirming the efficacy and safety of low molecular weight heparin in this setting. which is consequently the prophylaxis of choice in most patients, with a proven efficacy, reducing venous thromboembolism by half to two-thirds, and with acceptable safety profile and bleeding risk. So consequently, in surgical patients, prophylaxis has been enshrined in our practice for over 2 decades now. This is the World Health Organization Surgical Safety Checklist, which has been implemented in the UK. And there have also been studies in medical patients where 3/4 of the deaths due to pulmonary embolism, in fact, occur in medical patients. And there's also 3 randomized controlled trials, which we've heard described earlier this afternoon, which show an approximately 50% reduction in the risk of venous thromboembolism with the use of appropriate prophylaxis in acutely ill medical patients. About 10 years ago now, in 2004-2005, the Health Select Committee in the House of Commons in England highlighted the very significant burden of disease due to hospital-associated thrombosis, and with thousands of patients dying each year due to venous thromboembolism. And really that set in train a long journey, which I'm lucky enough to have been able to contribute to during this time. And for the past 6 years, I've been the national clinical lead for the VTE program in England. So we have, during this time, developed a comprehensive systems-based approach to VTE prevention, and this has been held up as a global exemplar for VTE prevention, whereby we've used system levers and a multidisciplinary approach to support implementation, and a kind of collaborative approach from VTE champions who believe this is the right thing to do for our patients have driven very significant change in VTE prevention as well as in outcomes. So for the first time, really anywhere, we put into place a national VTE prevention pathway using a national risk assessment tool, which was linked to clinical guidelines for reducing the risk in hospitalized patients, which were agreed by NICE, the National Institute for Healthcare and Excellence. And we made the collection of risk assessment data mandatory with kind of monthly submissions to NHS England. And VTE was the first national sequence target. Because really, we have been banging on about the need for VTE prevention for many years. But as we all realize, money talks. So about 6 years ago, we created a system called Commissioning for Quality and Innovation, whereby hospitals are paid between £500,000 and £1 million a year for quality improvement initiatives. And VTE prevention was the first quality improvement initiative. And the first target was to risk assess more than 90% of all adult patients admitted to the NHS. Now, that was a big, big ask, because prior to this, we were going around and saying, it doesn't really matter how you risk assess them as long as patients have appropriate prophylaxis. So this was a game changer. We made risk assessment, which is the trigger for the pathway, the main target. And NICE also produced a quality standard which defines best practice when it comes to VTE prevention. We also mandated root cause analysis of all cases of hospital-associated thrombosis and audit of thromboprophylaxis. So really, for successful VTE prevention, you need to identify the at-risk patient, counsel them about the risk, and then prescribe appropriate prophylaxis. Now, this doesn't project particularly well, but this is a national risk assessment tool. It looks complex, but it's actually quite simple. All surgical patients and all medical patients who are anticipated to be mobile for 3 days have to be risk assessed according to this tool. and both for the risk of thrombosis as well as the risk of bleeding. Now, there are over 20 risk assessment models available globally. None have been properly validated, and many of them are even more complex. You can either take a quantitative approach like the Caprini model or a kind of bucket approach where patients are either low risk or high risk. We chose the latter, and this risk assessment model then links into the NICE guidelines for appropriate prophylaxis. And I'm pleased to report these are the kind of latest results in the NHS in England in 2016, 2017. Over 90%, actually over 95% of all adult patients admitted to the NHS have their risk of venous thromboembolism assessed. Now, this is a big, big ask because each month in the NHS we have 1 million admissions. And in the past 5 years, as the population gets older and sicker, the number of admissions to the NHS has increased by 25%. So this has really been a huge achievement on the part of the NHS. And tomorrow, during my talk, I'll kind of look at how these changes have impacted on VTE outcomes in the NHS. So this is a big, big achievement. Over 95% of all cases are risk assessed, and then we have many thromboprophylaxis options, but really low molecular heparin remains the mainstay of thromboprophylaxis, whether in surgical patients or medical patients. The direct oral anticoagulants have a role to play in orthopedic patients for extended prophylaxis after hip and knee replacements. Clearly, for many decades now, we have been using anti-embolism stockings. But again, the evidence for anti-embolism stockings is largely out of date. So my colleague, Professor Alan Davies at Imperial, is currently conducting a contemporary trial of the use of compression stockings in addition to low molecular heparin. Because operative procedures have got more slick, operative times have got shorter, so I think it's very important to have contemporary data around stockings. Intermittent pneumatic compression, we tend to use for stroke patients and otherwise high-risk VTE patients like orthopedic and neurosurgery patients. The use of IVC filter really for prophylaxis is not generally indicated. There's some subsets, minority of patients, for example, after pelvic trauma and fractures, if they are unable to have low molecular heparin prophylaxis because of very high bleeding risk, we might consider the use of IVC filters, but generally not for prophylaxis. And there are very clear, nice guidelines around the care pathway and risk assessment, and about 17 different pathways for different groups of patients which specify the choice of prophylaxis, and they are very much aligned to the ACCP guidance, for instance. And we have a nice quality standard for VTE prevention, which benchmarks what high-quality VTE prevention should look like. And statements 1 and 4 relate to risk assessing the patients and repeating the risk assessment as the clinical condition changes. Statements 2 and 6 relate to giving the patient both verbal and written information about their risk, and the rest of the statements relate to the main reason for this quality standard, which is giving appropriate prophylaxis. So really, for implementing change, it's important to have common guidance across the healthcare system on risk assessment and appropriate prophylaxis. But changing practice requires a major change in culture within our hospitals, and in the next few minutes I'll kind of share with you some of the practical things we've done. One of the first things we set up at the outset of the program was that each hospital should have a thrombosis committee which helps develop and support good practice locally, And this is usually a multidisciplinary group which meets on a regular basis. And this really has proved to be a very powerful instrument for driving change, for agreeing guidelines, for auditing the implementation of the process. An ideal VTE protocol should be applicable across all the patients in scope, should be easy to access and to use, and it should link each level of risk to evidence-based choices for VTE prevention, and also list contraindications to prophylaxis and provide suitable alternatives. The important thing is to keep the process simple. It should be specific, measurable, achievable, realistic, and timetabled, and really incorporated into the workflow in the everyday workflow on the wards and in theaters, and designed to be reliable, initially piloted on a small scale, and then the use of the protocol should be monitored. A process called measurevention, where you introduce steps and then you monitor the impact on the outcomes. This is how we started off many years ago. These are local guidelines at King's. Again, it's available on our website. So this links the risk assessment tool to very specific guidance for all groups of patients within the trust, whether they're surgical, medical, or neurosurgical patients. And our current form of guidance is entirely electronic. So we have an automatic kind of risk assessment tool that you can't get beyond unless you've risk assessed the patient. And then this links into an electronic prescription for the thromboprophylaxis, which includes both the stockings as well as the chemical prophylaxis. And this is monitored in real time, that we have a trust VTE prevention nurse who at the end of every afternoon can in real time monitor which patients have not been risk assessed on the ward. So then she can ring the appropriate doctor and nurse and make sure that this process is undertaken. So really the pathway now is very robust. The patient is at the center of the process and at the center of everything we do. We have agreed a national patient information leaflet, which has been translated into many languages. We also have a website for patients in the NHS Choices, which includes a self-assessment tool, and we created a video to give patient information. This is based on the experience of Paul Robinson, who used to be the former England goalkeeper, who unfortunately developed pulmonary embolism after spinal surgery a few years ago. And we also have additional videos of patient stories of their experience around venous thromboembolism. And again, these websites are accessed many thousands of times from all over the world. So education clearly is a major part of what we do, both for healthcare professionals as well as for patients. And Health Education England has worked with us to produce these electronic training modules around VTE prevention, which take about 20 minutes to complete. And we have separate modules targeted at doctors, nurses, pharmacists within hospitals, and separate modules for undergraduates and for GPs as well as commissioners. And the original module now has been completed over 35,000 times and the certificate printed out, because really, and it's part of the mandatory training of all our doctors, nurses, pharmacists on an annual basis. And all that kind of data about who completes it is captured on a regular basis. Again, this is open to all. It's not password protected. So if you go to the website, you can easily access that. And then really we do a lot of awareness work at a kind of national level. where, clearly the champions of this process for many years have been the doctors, nurses, pharmacists who've seen the very significant morbidity and mortality within hospitals and who've believed this is the right thing to do. So along with my team, I kind of do these national visits to hospitals to kind of inspect their VTE prevention programs. And, it's amazing how innovative staff can be at kind of finding new approaches. Originally when we set this program into place, the NHS said that it would give each of the hospitals quite a lot of money, but it never came up with the money. But we still have a rather long list of applicants to be champions because just the kind of badge of excellence that goes with it. So the nurses and a kind of multidisciplinary approach are really crucial to the success of what we've done. The thrombosis team in my hospital alone comprises, in addition to 5 consultant hematologists, and we don't just do prevention. We look after all DVT and pulmonary embolism and anticoagulation. We have 7,000 anticoagulation patients. We have 1,000 VTE patients each year, as well as VTE prevention and the leadership role. So we have 12 nurses. We have 3 or 4 pharmacists and then kind of research staff. We have a thrombosis committee. We have nurses who treat DVT and pulmonary embolism, and we always have 1 full-time nurse doing VTE prevention at each of our sites. And on each ward, we have a named nurse who is responsible for VTE prevention on that ward. So they're called link nurses or champions. The nurses also help with doing the risk assessment in the surgical pre-assessment clinic. And on the wards, they ensure risk assessment and appropriate prophylaxis, and also help in providing patient information and in carrying out audit of VTE prevention, along with the kind of junior doctors on a quarterly basis. So really, operationally, this is what VTE prevention on the wards involves. It's a kind of multidisciplinary process. It's a multi-layered process with a gradual introduction of interventions. The thrombosis team, the link nurses, are very, very important in educating staff about VTE prevention. We have electronic systems, and as we can see at the bottom right of this slide, VTE risk assessment sits alongside other key indicators like infection control as a key performance indicator. And really, having support at the very highest level from the medical director and the chief executive of the hospital is absolutely essential. At the bottom left, you can see our chief executive modeling our VTE prevention T-shirts. So it is a lot of effort. And as is common, the politicians are very keen to kind of take credit for what we do, particularly if it's a success story. So this is our health minister who was visiting to see VTE prevention at King's. The patient here smiling in bed was a professional kickboxer who unfortunately managed to damage both his hips as a consequence of his sport and needed bilateral resurfacing of his hips. So he was risk assessed by the nurses in the pre-assessment clinic, given the patient information leaflet. When he was admitted to the ward, there's a nursing care plan for VTE prevention. He received suitable prophylaxis. He was mobilized early and given advice on discharge as to what symptoms to watch out for. And thankfully, he had a good outcome. So this is, it's not only a local effort, but it's also a big national effort. About 9 years ago now, we set up the VTE Exemplar Center Network for centers of excellence that work together towards producing high-quality VTE care. So currently, we've got 28 hospitals that are part of this, from 200 beds to 2,000 beds, and it really has become a kind of badge of excellence to be recognized as an exemplar center for VTE prevention and care. Again, here you can see on this slide just some of the kind of happy teams, and we also organize an annual big kind of VTE prevention meeting. So, preventing hospital-associated thrombosis has required a kind of comprehensive systems-based approach. But I think going forwards, sustaining and improving best practice in VTE prevention is a continuing challenge, because despite all of our efforts, there's a very substantial burden in the NHS of cases of hospital-associated thrombosis. During my talk tomorrow, I'm going to kind of cover the impact of all of these efforts on real-world outcomes in VTE prevention, because ironically, this is kind of one area in which we set out with very little knowledge of outcomes. With most quality improvement programs, you know what the outcome is, you put in the intervention, and then you look at the impact on the outcomes. Whereas with this, we started off because we were seeing the deaths due to pulmonary embolism. We knew it was a big problem in hospital. But after we put all these efforts into place to prevent VTE prevention, we were being asked, okay, show us that we are impacting on the outcomes. So that will be a large part of the content of my talk tomorrow. And I will also cover some of the grayer areas of evidence for VTE prevention, such as, for example, lower limb immobilization, nursing home, mental health care. So I'll stop at that point. Thank you for your attention.
Thank you, Professor Roopen. Our next speaker is pharmacist Mukhtar. Mukhtar has received his Doctor of Pharmacy degree from King Faisal University in 2014. He's currently in charge of the main inpatient pharmacy and has published many research articles in national and international journals. Let's welcome Mukhtar. You have your...